I am covering the questions from past test series, question bank, the orthopedic conditions. Let's see, start from question number one. Patients develop common fibular nerve. It is also called as common peroneal. After treatment, the below knee cast for 6 weeks for undisplaced ankle fracture. There was ankle fracture, cast was given, but nerve palsy is there. So the sciatic nerve, it is the main nerve, it goes down and divides into tibial nerve, which is the nerve of, actually sciatic nerve is nerve of posterior compartment, posterior thigh. Then it divides into tibial nerve and the common peroneal nerve, or also called as common fibular. So this common fibular and this is tibial nerve, common peroneal nerve. It takes a round turn around the fibula where it is commonly compressed. This common peroneal divides into superficial peroneal. Superficial is like this, and another is deep peroneal. So now this is deep peroneal, this is superficial peroneal. Basic, it is a nerve of anterior compartment. This has become the nerve of anterior compartment. Tibial nerve is the nerve of posterior compartment. So it is at the level of knee joint. So this is leg down. So leg has got anterior, posterior and lateral. Lateral compartment, the nerve of lateral compartment is superficial peroneus. Superficial peroneal nerve is supplying to peroneus longus and peroneus brevis. Peroneus longus and peroneus brevis. So these peroneus, these are the muscles which cause eversion. This is muscles are causing eversion, and skin supplies the dorsum of the foot. Dorsum of the foot. Here it is sensory and this is motor. The sensory part is, it is supplying to the dorsum of the foot. Now deep peroneal nerve is supplying the muscles of anterior compartment. Anterior compartment. So anterior compartment is causing dorsiflexion of the ankle. So this is eversion, this is dorsiflexion. What are these? Are main muscles. There are 4 muscles of anterior compartment. Tibial is anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. PT, peroneus tertius, extensor hallucis longus, extensor digitorum longus. 4 muscles. These are muscles of anterior compartment. These are dorsiflexors. Dorsiflexors supplied by deep peroneal. So it supplies to all these muscles important. Then some of the small muscles also. First extensor digitorum brevis, first dorsal interosseous, and then skin has got little supply to the skin of the first web. So first web. This is deep peroneal, skin this anterior compartment. So the question is, the answer should be, there will be no dorsiflexion. Patient is unable to stand on the tip of the toe. It means tip of the toe means a person is doing plantar flexion. The function of plantar flexion is by posterior compartment. The nerve of the posterior compartment is tibial nerve. So standing on the tip will be a function of tibial nerve. Tibial nerve will go down as a nerve of posterior compartment. So posterior compartment is functioning. There would be complete sensory loss below the knee. No, this is the below knee. Sensory loss complete means posterior part of the leg is actually having supply from the tibial nerve also. The patient would complain of complete sensory loss of the sole. Again, the sole, only first web is supplied by the, otherwise the tibial nerve is continued down from the medial malleolus. Then it is supplying to the sole also. Medial plantar, lateral plantar nerves. Sensation would be normal on the dorsum of the foot. Basically, this is lost because of superficial peroneal nerve. Superficial peroneal will lose sensation. So answer is there will be no dorsiflexion. Dorsiflexion you have got. What is the answer? Dorsiflexion of the foot requires functioning of muscles in the anterior compartment. So this is anterior compartment of the lower limb. Motor supply of the muscles come from the deep peroneal, which is a branch of common peroneal. The common peroneal, also known as common peroneal, is compressed by the below. Patient, this is standing on the tip of the function of muscles of posterior compartment. So lower limb, gastrocnemius, tibial nerve is the nerve. There would be complete sensory loss below the knee. Sensation below the knee is supplied by a number of different peripheral nerves, deep and superficial peroneal. Tibial nerve is also involved. Saphenous nerve is also involved. Sural nerve is also involved. These are nerves which are spayed. Sole of the foot, sensory fibers of the tibial nerve and terminal branches of medial and lateral plantar nerves. Sensation would be normal on the dorsum. Common peroneal supplies sensation over the dorsum foot. The deep fibular nerve supplies skin over the first wave, and superficial peroneal supplies the dorsum of the foot. So this you have to understand, because all the questions are around this: sciatic, tibial, common peroneal, superficial, deep, superficial peroneal, dorsum of the foot, deep peroneal only first wave, and this is dorsal. Lateral part is sural nerve, that is superficial nerve. Medial part is the saphenous nerve, which is a branch of femoral, continuation of femoral. So next question is, following open reduction, internal fixation of both the distal tibial and fibula. A patient complains of numbness along the lateral side. This was not present before. So lateral is sural nerve. Next question. Young patient is tilting her pelvis while walking. Tilt of the pelvis while walking. Difficulty in maintaining independent mobility. What is clinical test to assess hip abductors? Hip abductors. Abduction means why it is required. It is a Trendelenburg test by gluteus medius muscle. They try to lift. So when you are lifting the opposite side, because the opposite side of weakness, see, this is, suppose this is a pelvis. This is the pelvis, and this is one side, this is another side. So gluteus medius on the both sides are attached like this. This is left side, this is right side. If this is paralyzed, for example, this one is paralyzed, left side is paralyzed. So what will happen when a person is trying to lift this leg up? So this will not be contracting, this is just relax. So pelvis will tilt on this side. So opposite side, paralysis is on this side pelvis will go down. That is Trendelenburg test. Paralyzed hip abductors. This test is performed on the patient standing. Patient asked to raise one leg. The test is positive if the pelvis is raised side drops. This is the raised side, it is dropping down. So the opposite, the positive test suggests weakness of abductors of the other hip. So this hip abductors are weak, so this is dropping down. So next question is, 68-year-old man. Thomas test is performed for the hip flexion contraction saw syndrome, Ortolini test, and Barlow's. Barlow's is just you are trying to make the hip joint out, congenital, and Ortolini you are fitting it back. Ober's test is tightness of the iliotibial tract. So Barlow and Ortolini. Barlow is influenced is the development dysplasia of the hip, assessing stability of the hip, which is performed along with the Barlow's test. Question number 4. 68-year-old man presents with a mechanical hip pain. He undergoes routine AP plan and lateral. Which is the first radiographic sign to appear in osteoarthritis? So there is a hip joint. This is the head of the femur, and this is the acetabulum. It has got it deep. So osteoarthritis, basically it has got, these are the surfaces, and here is the capsule of the joint. So arthritis, narrowing joint space, osteopenia, osteophytes, soft tissue swelling, subchondral sclerosis. So possibility the joint space narrowing may be the late after destruction of lot of this tissue. This tissue has to be lost. It is first radiological sign. This may start with sclerosis or narrowing of joint space. Let us see. Yes. Degenerative joint disorder which results from loss of hyaline cartilage and synovial joint. First sign is osteoarthritis is uniform, non-uniform joint. This is non-uniform. Some part is that is the first sign. Okay. Subchondral sclerosis is not there now. So the next question is 10-year-old girl treated for tibia and fibula fracture. Fibula and tibia, both bones. Above knee plaster cast, recurring over, but nurses are concerned having asked to review her overnight. There is compartment syndrome. Now tibia fibula fracture is there, compartment and loss of dorsal space, mottling of the skin, pain out of proportion. This is the actual sign, pain out of proportion. A 30-year-old man complains of having to swing his body to help him to walk. A person, while walking, he wants to swing the body. After a long session of exercise in gym, tender test is performed. If left side of the patient's pelvis drops while he stands on the right, so there is weakness on the left hip abductors. Right side pelvis is dropping, means left. Just a minute. Read the question. What is if left side of the patient pelvis left is dropping here, so right has to be weak. Opposite side. Next question is 38-year-old builder, bodybuilder, old builder's laborer sustained a severe fracture of left elbow. This is elbow joint, which damaged the ulnar nerve on the medial epicondyle. The month later, he still has total ulnar nerve palsy. So this is the ulnar nerve palsy. Ulnar is applying to the hypothenar and all the fine movements of the fingers. Sensory loss over the ulnar 3.5. No, it is 1.5 digit. Inability to grip a sheet of paper between his fingers. Yes, this is pad adduction movement. A 49-year-old woman has complaining of the tingling in her right hand at night. This is a woman commonly, and her hand is swollen and there is no obvious edema. The last few days has noticed numbness in the right index tip of the thumb, especially while working. This is a median nerve carpal tunnel syndrome. An 18-year-old falls out of the tree and injures his arm. Subsequently, his hand appears clawed. This is claw hand. On examination, hand is extended at metacarpophalangeal joint. So there are 3 joints. Distal 1, 2, 3. 1, 2, 3 carpals, then metacarpal bones. So this is metacarpophalangeal joint. What is there? And this is DIP, this is proximal PIP, and this is MP. Extended, it is extended. So what I am doing, extension is like this. Metacarpophalangeal joint is extended, and all interphalangeal joints are fixed flexion. So if you see this, they are all, this is like this, this is like this, this is like this, means all these are fixed flexion and this is extended. These all are flexed and this is extended. Klumpke's, this is just like a Klumpke's paralysis. So it has to be on the lower root, C8T1. This is Klumpke's palsy. Now next question is 37-year-old. This 37-year-old woman is in the hand clinic with the paresthesia of the thumb, index and middle finger. With positive Tinel's Phalen's test, positive carpal tunnel syndrome is made. Which of the following is correct regarding the diagnosis? May be caused by metabolic disorder, gout, diabetes, hypothyroidism, maybe inflammation of the anesthesia of the little finger, may wasting of the abductor digiti mini, occlude the ulnar nerve. It is median nerve, may be caused by the gout, diabetes and hypothyroidism. One is the, so it is because of 54-year man is seen outpatient clinic, long history of positive worsening